Good morning, everyone. I'm Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we welcome you to today's webinar, Behavioral Health Among College Students, Substance Misuse, and we're excited to have speaker Haraylee Martinez-Cabrera with us. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you might have as you think of them, and the presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and those options are posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You will be connected to the audio of this presentation and view it on screen as well as receive a certificate of attendance. The recording materials used in today's presentation will be available on the FADA website within 30 business days. One helpful hint is the archive video displays what looks like to be an error message, but it's only a delay buffer, so just ignore it, hit play, and enjoy. To access the recording and PowerPoint, go to www.fada.org, Resource Center, and Training Library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 5 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at midnight on Monday, March 2nd, 2020. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed health practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification form when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credits. And now I'd like to present our presenter, Haraylee Martinez-Cabrera. She is an educator, advocate, and activist and operates a private practice and works as a therapist for River Oaks Treatment Center, where she serves college students and young adults. Her primary focus is to assist young adults gain the skills required to achieve and maintain their sobriety. Ms. Martinez-Cabrera specializes in cultural competency and behavioral health needs for the young adult community. I apologize. One moment, please. Okay, I apologize for that delay. Haraylee, if you're ready, we're ready to hear your presentation. Thank you.
All right. Thank you. Thank you, everybody, for coming in today. So my name's Haraylee. I am a therapist and licensed clinical social worker here at River Oaks. I also operate a private practice, and with me, I do have Dr. Murphy.
Hello there. I'm Dr. Michael Murphy. I'm the medical director at River Oaks, and I'm a psychiatrist and an addiction medicine specialist. And I've worked with Haraylee for a couple of years now, and I'm really excited to have you hear her presentation, which she's worked very hard to put together for you.
All right. So just a few of the learning objectives that we're going to be going over is learning about the scope of the drug and alcohol use and mental health disorders in college students in the U.S. and especially in Florida. We'll also be going over the evidence for early identification and treatment in young adults, as well as learning about best practices in college-age populations that could be utilized in the colleges and universities here in Florida and even nationwide. All right, so kind of to just go over some of the history is starting off with the history of substance use in the different college populations. We'll start with the age of exploration, which spans from the 60s to 1975. It started going over the therapeutic benefits of LSD and exploring what that meant. This included having huge colleges and universities funding research studies such as Harvard, and kind of looking into, hey, how could we benefit from LSD? Obviously, those studies didn't really make it very far because we don't really hear from them anymore. And then also back then they were a huge countercultural staple. It was a lot of the going through the community of being free and not really caring about what other people were thinking. There was also research on creative or spiritual enhancement, which began in 1960, where some people were using certain substances to have more of a spiritual awakening. And then we also noticed the amphetamine epidemic, which peaked around 1969. The next phase kind of went into the Just Saying No campaign, which spanned from 1975 to 1990, where this is where the National Institute of Health's Monitoring the Future study began in 1975, and this study has continued throughout until today. There was the Anti-Drug Abuse Act of 1986, which was also known as the Len Bias Law. And this came from the impact of substances on students and recognizing how there were certain students and student athletes that were greatly impacted by the substances that they were using. In 1980, there was a huge decline in hallucinogens, but continued increase in cocaine and amphetamine use in the colleges. And then in 1987, there was a revision of the DSM that allowed stimulant medications to be prescribed to school children. And I think this is where we start to see a huge peak in the diagnosis of ADD/ADHD. Now we come to present day, which started back in 1990. So for about the last 30 years, there's been a larger focus on having the whole better than coffee and having more of drugs in academia. There has been a new trend of illicitly diverting prescription drugs. Right now, I think everybody has been pretty focused on the millennials. And the millennials is anybody that was born between 1982 and 2000. And something that I found really interesting is that they are known as Generation RX. I think that provides a huge symbolism when it comes to the ADHD epidemic of the 1990s and starting to prescribe medications left and right to address a multitude of issues. And then there has been an increase in state-by-state cannabis use exemptions, where I think we're starting to see the information coming out with how cannabis is impacting people long-term, as well as figuring out the recreational versus medical uses. All right, so some of the current trends with marijuana use is, I think overall, as we've seen through the history of things, it's going through and recognizing that we went from a recreational purpose when it came to substances to more of a functional purpose. Now, working in addictions for the last 4 years or so, I'll hear a lot of people talk about, hey, I'm a functional addict, I'm a functional alcoholic. And that's where I tend to tell them, it sounds like an oxymoron because it's hard to be functional when you're dependent on a substance. So I think people now are using substances for more of a functional purpose, and I think that is allowing people to rationalize and justify their behaviors. So with the annual marijuana use, it's at its historic highs with college and non-college peers. As you can see in the graph, with the non-college and the college, it seems like this is we're finally at the point where we meet each other, where the college population seems to be a little lower than the non-college population. And it is also the most abused substance. Some other information that I have found is that there is daily or near daily use of marijuana, which is twice as high among the non-college group. So 1 in 9 non-college respondents reporting daily or near daily use of marijuana, which is compared to 1 in 17 college students. So that's about double right there. And for this, it only counted for those that used at least 20 or more occasions in the last 30 days. So it doesn't count for those that maybe smoked once a week or about once a month. All right, so in this graph, there is a larger focus on understanding the use and comparing the use between the different substances and the college and non-college students. As you can see on the left-hand side, you have the alcohol use, where the college students have the non-college students beat out. And this is also, you can see, where it's up to 60%, and pretty much the college population is higher other than with cannabis, cigarettes, hallucinogens, and opiates. I think it's also important to point out the differences in the substances that are being abused and not abused. When it comes to the vaping trends that we've seen, I think it speaks for itself with the recent legislation changes and how now somebody has to be 21 years old to purchase tobacco products. And I think this also goes into availability where, you were able to go through the mall and buy any kind of vape juice with any kind of flavor, such as bubblegum, watermelon, blue raspberry, and I think that has also increased its popularity. And I think the other part too has been with understanding the just social acceptance of vaping versus cigarettes. I think people have gone away from cigarette smoking and used vaping as more of an okay method to taking things. All right, so with this, from 2017 to 2018, it's been the greatest one-year increase for any substance in the history of this. With nicotine vaping, as you can see when it comes to the college students, it almost triples in 1 year, whereas with the non-college students, it goes up about 5%. So I think kind of just going through the acceptance and the popularity of it all, it definitely speaks for itself. All right, so now we go into the binge drinking. I know we've been talking about substances a lot more, and I know it's a lot of information. So with the binge drinking, I think the most outstanding thing is really seeing how it's below 30% for the first time among college students. Now, binge drinking is considered when somebody is consuming about 5 or more drinks in a row. Some possible contributing factors to this, I think it could be come down to seeing the differences in people accepting the use of other substances, as well as recognizing that they have other options to use, such as you have vaping, you have nicotine, you have prescription substances. I think they're starting to spread their attention to it a little bit different. All right, so some risk factors with these substances is the availability is widespread. Right now, it doesn't take too much to find certain substances. For example, you could be in a library studying for finals, and somebody could be like, hey, do you want something? It doesn't take a lot of effort. The other part is the decreased ability for parents to have that direct protective effect. College is the first time that students are able to be on their own and that they're able to explore who they are a little bit without being under mom and dad's thumb. There's a perception of the social norm where some people that are trying to be sober or trying to maybe not use substances get looked down upon, or they get questioned a lot more. And then you have the low to moderate perceived risk of consequences, and that's more of just people thinking that they can get away with more. Especially with just how available everything is and how some things are becoming more legal. It's at that age, not a lot of people are thinking about, hey, this is what I can lose. All right, so some of the higher risk groups include the fraternity and sorority students. As we probably all know, when it comes to fraternity and sororities, it is culturally accepted for them to have huge parties that include a lot of drinking. We'll see them in the news about incidents that occur. You have LGBTQ plus students, where you have studies that indicate that when it comes to that community specifically, about 20 to 30% end up abusing substances, including alcohol, which is significantly higher than the general population at 9%. And a lot of this, too, comes with what does it mean to be LGBTQ plus and going to college and trying to come out, trying to figure themselves out. So just a little background information. I recently also presented at the Behavioral Health Conference in regards to the LGBT population and going over the risk factors involved in how there may be an increased need or perceived need for them to be accepted because they're trying to figure that out on their own. And then you have student athletes. There are a lot of unrealistic expectations that are placed on student athletes, both physically and with their education. They're expected to practice several hours a day, almost every day, as well as maintaining high GPAs. And it gets to the point that it's either, do I sleep or do I take another Adderall? And then you have certain students with mental health conditions, so you have higher comorbidity, where they start to use substances to self-medicate with their addiction and mental health. So before we go into Greek life, I think it's going to be important to understand that a lot of these students have so much going on and have a lot of unspoken expectations where they feel like they have to do their best. And this is where we're going to start to break it down to figure out, okay, what's been going on and how does it impact these communities specifically. So with Greek life, there's an enabling environment for drinking. Like I mentioned before, there is a huge social expectation that, hey, if you're in Greek life, you party. I know for anybody that went to any kind of major college where they had a set Greek community, there would be several nights, I know even for myself, I would walk by and I would just hear the parties. And I think for some, it's somebody that's trying to minimize their use or trying to avoid the drinking at all, it would be very difficult in this environment. According to a study in 2012, they noticed that there was a $500,000 annual cost per university for alcohol-related emergency department visits. So this could be anything from getting hurt while just drinking, whether it's tripping or any kind of assault that occurred, or even alcohol poisoning. And then with the alcohol consumption with undergrad students, the annual contributions were about 600,000 unintentional injuries, 700,000 assaults by another student who was drinking, 1,500 alcohol-related student deaths, 97,000 sexual assaults, 400,000 acts of alcohol-related unprotected sex, and 100,000 incidences of being too intoxicated to know if sex was consensual. Now, these numbers seem astronomical, and I think the other part too to consider is this is just what was reported. This doesn't account for anybody that had alcohol poisoning and tried to treat it themselves in their own bathtub or in the bathroom with their friend. This doesn't account for any sexual assault that wasn't reported or any incidents of unprotected sex or being able to remember if the sex was consensual. All right, so continuous Greek life, I was able to look into something where there was an alcohol-free fraternity that was able to maintain its membership and focus on recruitment, promoting the benefits, environmental factors, providing social alternatives, and focusing more on the brotherhood and the friendship with the fraternity while also enforcing alcohol-related rules. With this fraternity, it was at a Midwestern university during the 2012-2013 academic year, and it consistently ranked in the top tier academically. Unfortunately, this is a very rare occurrence where you'll see an alcohol-free fraternity. Hopefully, it's not the same case now, but I think even recently in the news, you'll see a lot of incidences that have occurred within colleges where colleges will take the approach of banning alcohol or trying to figure out how do we prevent this from going on and making it look cool, so to speak, to not be drunk every day or to not have these intense parties where so many people are drinking. All right, so for psychiatric disorders within college populations, you'll see that there's a peak onset during the young adulthood. As we all know, that usually by age of 25, 75% of those that will have a mental health disorder have already had their first onset, whether it's with anxiety and having their first panic attack, whether it's having a major depressive episode, any signs of mania or depression for bipolar disorder, as well as for schizophrenia and the other psychiatric disorders. When it comes to college students suffering from mental health disorder, the highest is those having an anxiety disorder, and this is similar to the entire population where anxiety disorders are the highest diagnosed. And then you go from anxiety to depression to bipolar disorder and ADHD, which the range is about between 2 and 8%. Now, when Dr. Murphy and I first saw this statistic, we noticed how it was a little bit lower than we expected because so many people nowadays come in with like, hey, I was diagnosed with ADHD when I was like 8 or 10. But I think it's just important to keep in mind that with this study, it focused on that snapshot for those that were in college. And if we're talking undergrad specifically, it's usually from 18 to 22 or 23 years old. And then on a survey of about 8,200 students, almost 7% reported having suicidal thoughts, with 1.6% having a plan, and then 0.5% reporting making a suicide attempt in the past year. All right. And there's also a prevalence of psychiatric medication prescribing, where a lot of the psychiatric diagnoses that were occurring are now starting to receive medications. I think that the biggest one being the surge of prescribing any kind of ADHD meds. There's also the diversion that comes with those increased prescriptions, where about 28% of college-age young adults report having misused some type of prescription psychotherapeutic drug at least once in their lifetime. And this can vary from somebody using maybe grandma's Xanax to stealing their younger siblings Adderall or Ritalin, or borrowing from each other. All right, so when it comes to amphetamine use, I think this tends to be the big one that we all assume college kids abuse. There are some significant gender differences with the past year. If we look here on the left graph, you have the college and the non-college with a 3% difference. And then you have with the college males abusing at 14.6% and the females 8.8%. Now, this may be due to there are more college males in sports, so they have that student-athlete pressure of trying to do 2 to 3 hours of football practice and then acing their biology exams. And then you have the non-college population, which varies from 5.3% to 10.1%. And then this motivation may be different too, where it may be to more societal expectations. If you have young single mothers or young parents, that may lead to the impact of that, as well as those that have abused Adderall in the past have done it for weight and trying to manage their weight and trying to become perfect, or what they believe is perfect. So we went over some of the gender differences and the differences between the college and non-college populations. Another thing to point out too is just there are different motivations for everybody to abuse these substances, and it kind of goes into having 15.3% of the women that were from 16 to 24 years old reported abusing amphetamines for weight control purposes. All right, and then when it gets into opiate use, it's when you have the college and the non-college, it looks like the non-college population beats out the college population in both 2013 and 2018. Now, for this, it looks like it's narcotics other than heroin in the survey, so anything that can range from Vicodin to Percocets to Oxys, and at least there is that benefit of knowing that the use has dropped, but this may be due to the legislation that has occurred with getting tighter on physicians prescribing substances or prescribing opiates, as well as getting, shutting down the pill mills that we saw a lot of, especially here in Florida, where we noticed that a lot of people would come down to Florida to visit several pain medication clinics and then go back to their home state. So the non-medical use of each prescription medication were usually greater for males, whites, members of social fraternities and sororities, and those with a lifetime history of medical use of prescription medications, or past year history of being approached to divert their prescription medications. So if they were approached at any time of, hey, can I have this? I know you were prescribed this at one point and you may have some leftovers. They're more likely to share their medications with other people. And I think the history with those that had a lifetime history of using the medications was when legislation tied up with shutting down pill mills and being more aware of what was being done. It's those that stopped being able to receive all of their medications had to go through different ways to do so. All right, so some of the effects of substances on college performance and social functioning. So when it comes to learning and substance use, there are the undergraduate students that are about 18 to 22 had significantly higher rates of marijuana use and binge drinking compared to their graduate student counterparts that were about 23 and older. So of course, if I'm showing up to class while high or hungover or possibly even detoxing because I went on a binge of using some benzodiazepines or some opiates, I'm not going to be performing in class too well. There's also the peer pressure of, trying to be one of the cool people in college and trying to fit in. Again, this is where a lot of people try to discover themselves, and it gets very confusing and overwhelming when here I am trying to figure out who I am, and I have somebody trying to give me Adderall so I can party and then pass my exam in the morning. And then we have the risk-taking behaviors who, students who misuse pain medications were more likely to have a lower GPA. So misusing the medications as well as engaging in high-risk behaviors of maybe driving while under the influence of substances or alcohol. So some of the outcomes of substance use in college is the delayed college completion. Of course, if I'm not passing my classes because I was showing up hungover or not being able to get to an exam because maybe I slept through it or I fell asleep because I was high, it puts off being able to graduate college. And then those who use prescription stimulants and anxiolytics, which are benzodiazepines, reported use of abusing other substances and risky driving behaviors. So some of the statistics with graduation rates in Florida and national. So for Florida, for this past year, we had a graduation rate of about almost 62% and a transfer out rate of about 13.56%. Now with transferring out, it essentially just means dropping out. When it comes to the national average, what I was able to find is differences in public colleges and private colleges, where with a 4-year graduation rate, it was at a 33.3, and then a 6-year is a 57.6. Again, this goes back to the effects of the substance use and delaying the completion of college. And then it's a little bit higher within private colleges and universities at almost 53%, and then a 65.4. And this may be due to those that are able to afford to go to a private college probably are trying a lot harder to be able to stay put. in their college and not lose what they were able to gain from attending a private college, because they also tend to give some specialties like more liberal arts colleges or having more of a creative field. So some additional consequences that comes with the addiction and being in college is the increase in unplanned pregnancies, where the unplanned pregnancies come from not having protective sex. And then not having protective sex comes with an increase in STIs. And then you have the risky sexual behaviors where somebody may unwillingly engage with multiple partners at a time, where it's not consensual or they don't remember. And as you know, as we all know, somebody can't consent to sex if they're under the influence. So it leads to a lot of people having that regret and trying to figure out, hey, did I want this? Did I not want this? Or who did I want this with? And another part with the safety risk is, so sorority members who binge drink are significantly more likely to be injured, drive into the influence of alcohol, and be sexually victimized and engage in unwanted sex more than their non-Greek female binge drinkers. So just separating the Greek life from the non-Greek life, it looks like those that, even if they both binge drink, the behaviors become riskier and more dangerous for some reason because of all of the other expectations that come with being in a sorority. So with prevention and early identification, there are strategies for early identification, so identifying risk factors such as at the individual level, interpersonal level, and community level. So with risk factors, it goes into, hey, if I have a family history of depression or addiction, I may want to be able to keep an eye out on that when I get into college and maybe not go to the parties, or if I do go to a party, having a friend that I can trust and stay sober with, or at least they can keep me accountable of like, hey, I only want 2 drinks and be able to stay there. With the interpersonal levels, is there communication with each other, having those spoken and unspoken rules be discussed. And then you have the community level, like trying to develop those new social norms, where it's maybe providing an increase in being able to, an increased acceptance of being sober, an increased acceptance of not having a party all the time. So I think just even providing these resources in the beginning, it will allow people to identify that they don't have to engage in these risky behaviors. And then you have the residential education with implementing mandatory courses in orientation, as well as counseling centers on campus. So from what I've seen, there are several major universities that provide counseling to their students. Unfortunately, sometimes they tend to be very limited to either 6 sessions, 10 sessions. Recently in my private practice, I started working with a college student, and it is a community college, so I'm glad that they were able to provide free counseling. But unfortunately, they only provide 3 individual sessions for this client. And it's hard to work through, all right, I have 3 sessions to address a number of issues with this client. Realistically, how much can I do? Right? It seems like it's more appropriate for like crisis management, but when it comes to being able to maintain a healthier lifestyle and addressing long-term mental health issues, it's probably going to take more than 3 sessions, especially when one of those sessions being the intake and gathering the history. So I have a story here from one of our employees with American Addiction Center. We're going to be playing about a 12-minute audio clip. So I think Karina will be doing that for us.
We're going to take a quick break, and I'll have that audio pulled up when you get back. Thank you.
Mute.
Okay, if everyone's back from break, we'll go ahead and play that audio. Thank you for your patience.
Thank you. So just a little bit of a background. This is Missy Pollock. She is a graduate from the University of Florida. She also works with American Addiction Centers. American Addiction Centers, um, basically it's a nationwide, and they have like a podcast where they interview a lot of people and their addiction, and I think this was definitely very appropriate. You know, she graduated from University of Florida, and I think it puts it into perspective of how, it goes from trying to be cool, trying to fit in, doing what everybody else was doing, to it was impacting her daily life. It was becoming a cycle where it is very common that people go from abusing uppers or such as like Adderall or Ritalin and using benzos to come down from them. Because if you abuse Adderall all the time, you could stay up for days at a time, and at some point you know you need to sleep, because that's where the paranoia sets in. That's where you start to have some very complex symptoms. Even some people might even have like psychotic symptoms, where they start to have hallucinations and stuff because they haven't slept. And as you can hear in her voice too, is she went from being this person that had it all, right? Had her future, she was working full time. I think with everything else we rationalize, hey, if I have a job, if I have a roof over my head, do I really have an addiction? All right, do I really have a problem? How do I go from being this person that got into this great university, was doing so well, to most of my money is going into my addiction now? I think the secrecy, and you can hear how she went through that desperation too of something has to give. Something is going to just have to give in, and it's either I lose my livelihood or I lose this addiction, or it's my mental health that can become even worse. And, it took her brother finding that Adderall pill to be able to get there. And I've worked with clients where they, tell me, hey, you know what, I stopped hiding things so well because I just wanted somebody to find it. I wanted somebody to catch me. I wanted somebody to be like, what's going on? Because people get really into just wanting help but not knowing how to ask for it. So hopefully this gives a little bit more insight, especially after all of those statistics and the information that I've thrown at you so far. I think sometimes, especially at this level, with the statistics, we see how astronomical things are. It's like, hey, if that many people are getting assaulted, or if that many people are dying from it, why do people keep doing it? And I think hearing somebody's story, you can understand why it's so hard. You can see how it becomes so difficult to go from being that person in college, trying to get through the day-to-day, to I can't get through my day without any substance. So what we're going to be doing is taking a 5-minute intermission, and I will have Karina get us there.
Okay, so if everyone can be back around 11:08, that would be great. Thank you. Hello, everyone, and welcome back from break. And Harayli, if you're ready, I'll turn it back over to you.
All right, thank you. All right, so now that we've gone over the story and being able to understand the statistics a little bit more, this is where we go more into the intervention part. And what do we do now? We know the information, we know the statistics, now it's putting things into action. So from what I saw, there tends to be a multi-level approach to things that seem to be effective. So this first one kind of going over wet schools versus dry schools, which just means where alcohol is permitted on campus and dry schools where it's not allowed. So with dry schools, it's about 30% of the students will abstain from alcohol, and then where only 16.1% will abstain from alcohol at wet schools. But something that was pointed out was the students who drank while attending either type of school, their patterns didn't differ from those at, whether you went to a wet school or dry school. If you drank, the behavior stayed the same. It just looks more like more people were abstaining from alcohol at the dry schools, so you had less people engaging in those riskier behaviors, but the behaviors were risky regardless. So the other part too is having mandatory participation in orientations for colleges and universities. So recently I have a client that I've been working with, and she enrolled at the local university here, which is University of South Florida. And she was required to participate in courses that address mental health, suicide prevention, and substance abuse. And how it was described was like a choose-your-own-adventure where you were given a scenario and then asked, okay, what would you do now? And obviously they would have moments where you would say, okay, probably not do that. And how would you talk to somebody that's suicidal? How would you talk to somebody that was struggling with an addiction? Showing them where the resources were. Further looking onto the website for University of South Florida, they had a list of resources available for, hey, if you're looking for a treatment center, these are some of the options. They also even provided some assessment tools to help figure out, hey, these are some issues that you may have. I may also be bragging a little bit because this is where I did go to school. So I'm a big advocate for the universities that provide that kind of information, even though it might be forced, and I'm sure there are plenty of students just trying to click through as quickly as possible so they can register for classes. I think it at least allows them to have exposure to the information. All right, so when it comes to illicit drug use, this is for use among 12th graders. So before getting to college, it was found that for them to use any illicit drug, it was about 38%, and any illicit drug not including marijuana, it was about 11.5%. So it looks like the majority of the drugs that were being abused was marijuana, followed by LSD, synthetic cannabinoids, which is also known as spice, cocaine, and MDMA, and then heroin. And then it was found that students who started alcohol and marijuana use before going into college were more likely to become regular users and abuse other substances while in college. So this is also going to be important to understand how do we intervene at the high school level or even younger to lower this statistic. As you all know by now, or most of you might remember the DARE program. It started back in 1983 and ended around 2009. And even though its intentions were good, it wasn't proven to lower the risk of substance use. So I think it's trying to figure out too, how do we address this where it is more effective. So having education about the impact of substance use is going to be a big part. I'm sure you remember some commercials that we've watched in the past where they crack an egg into a pan and show that this is your brain on drugs. So having education definitely makes an impact. I know they did the same with addressing the tobacco companies and those commercials where people have had major medical interventions because they had a lot of serious issues because of their smoking. And also identifying and listing appropriate resources is always going to be good because sometimes people do better with doing their own research, especially when they have questions they might be too embarrassed to ask. The other part is learning how to challenge the stigma and just allowing it to be more okay with not being an addict or not abusing substances, not smoking weed. So I think there is this huge focus of trying to be the cool kid. And then with Greek Life, intervening to prevent dangerous incidences. In November 2017, Andrew Coffey was a 20-year-old fraternity pledge at FSU, and he died at an off-campus party following a night of heavy drinking. I believe right after this occurred, FSU banned alcohol on all campus functions and parties, even to the point of, even with the graduate programs, none of the funding that was provided for any kind of events was allowed to purchase alcohol with. And kind of working towards developing that new normal where it's, hey, we can have a party and not have to chug as many beers as possible to prove how cool we are. The other part, too, is parental engagement, having discussion about the family history, whether it be with mental health and addiction, because those that have mental health issues tend to develop or at a higher risk of developing an addiction because it's hard to figure out how do I medicate what's going on. Hey, I'm feeling depressed all the time, but I know that if I take this Adderall or if I take an upper, so to speak, I can get work done. But it's, hey, we have a family history of depression. There are other ways that you can address this without using these substances. And also talking about addiction, too. There are several families that have a history of addiction that just don't talk about it. And even though it's an uncomfortable conversation, it's very important to figure out, just like at any kind of medical appointment and anybody's like, what's your family history? It's just as important to mention cancer, just like it is important to mention addiction. One of the other ones, too, is having peer supports like 12-step meetings like AA and NA, who we have Celebrate Recovery, which is more religion-based but approaches the same 12 steps. And then we have Recovery Dharma, which provides a more Buddhist approach to recovery, and it focuses on the 4 major components of it, starting with how addiction creates suffering. And then we have a map here of the United States. So this is specific to the Collegiate Recovery Program members. So the Collegiate Recovery Program is a program that there are only 138 participants in the United States and only 2 in Florida. one of them being the University of Tampa and the other being UCF, which is the University of Central Florida. And they provide specific resources to those that are in recovery or trying to get sober. They'll provide 12-step meetings. They'll provide specific housing for those that are in sobriety. And I've actually had clients that have transferred universities to ones that have this program to help them stay sober, because that conversation of, I don't know how I'm going to go back to school and stay sober, because none of my friends are sober. They look at me like I'm weird if I say that I'm sober, if I deny a drink or I deny a drug. So I think being able to engage in this type of program will allow them to be able to stay focused on their sobriety while still trying to get a degree. And it has been shown to really help those students have that support. All right. So with the major part of the intervention process that we're going to be going over here is the SBIRT, which is focusing on the screening, brief intervention, referral, and treatment. And it goes through a process that we're going to be breaking down. This is just the overall graph where you start with the screening process, and then you assess for the risk of the individual, and depending on their risk, depends on what type of intervention is to be used. So it could go from no further intervention when they have no or low risk to referring to a specialty treatment program, where this will include like residential treatment for those that have a severe risk or dependence. All right, so with the screening assessments, there are so many different assessments that can be used. You can use the audit, the drug abuse screening test, the ASSIST, CAGE, and the NIDA drug use screening tool. When it comes to this, it doesn't really force you to use any specific type of assessment. It just wants you to assess for what's going on. So I know for some places, maybe a more brief screening may be more useful, because I know sometimes too I'll have clients that if I give them like a 30-question assessment, by question 10, they're just going to circle like either 3s down the middle or the extremes without really putting thought into it. And then after the screening process, you go into the brief intervention, which would include either single or multiple sessions. This could be something as single being like a single crisis intervention, or kind of just having a discussion of, hey, this is what's going on, or how is your use impacting your ability to function, or even having multiple sessions like 3 to 6. And then we have the brief treatment, or the brief intensive intervention, where they complete an assessment and then they do a limited number of clinical sessions, typically around from 6 to 20, depending on how things are, to address any unhealthy cognitions, which is just those thoughts that help rationalize our behaviors, like, hey, it's okay that I'm taking Adderall, I only do it during finals week, and really learning how to challenge those thoughts like, it's not okay even if you say it's only during finals week. And the other part with behaviors associated with the current use patterns and adopting change strategies. So this also goes into identifying those behaviors that they may not understand are dangerous, like driving while under the influence, or if they have a job and going to work while they're under the influence, they can really hurt themselves at their work. And then there's also a potential challenge to implementation is that substance use disorder clinicians that are more trained in traditional long-term approaches might be resistant to this or not well trained in structured brief approaches. If you're used to having clients for 6 months to a year to several years, if somebody tells you, hey, you only have 6 sessions to do this, it can be a little overwhelming and not knowing how to have that more solution-focused approach. And then the last part of the SBIRT is the referral to treatment, where you provide service, there's providing services on a full continuum of substance involvement. You target people who don't yet meet criteria for a substance use disorder, and providing effective strategies for early intervention before the need develops for more extensive or specialized treatment. So this where there might be a referral. Some people might need to go to treatment. Some people may need to do like an intensive outpatient program where traditionally they're about 3 hours a day, 3 days a week in order to figure out how to cope with things, or referring to somebody that specializes in addiction to be able to intervene. And what these next 2 slides are is just a list of the different types of assessments. This was taken off of the SAMHSA manual for the SBIRT, and kind of just goes through each different instrument, the population it would help, the description of the instrument itself, and then where to get it. As you can see, that some of them might be more specific to adults, some of them will be adults and adolescents. And then with this last one, even providing information on adults and pregnant women. So again, you'll see some of them are like 28, 20, 6. This one sounds very helpful and quick because it's 1 to 7 questions with the NIDA drug use screening tool. So again, it's kind of just figuring out what's most appropriate for the agency. All right, so with brief behavioral counseling interventions, with follow-up, it can lead to small or moderate reductions in alcohol consumption, where they were able to find the reductions were sustained for at least a year. It was also effective in different settings, including primary care, emergency departments, community health centers, and then schools and colleges. And then while being used in a primary care setting, between 8 and 18% of patients screen positive for abuse. So this is, people are going to their primary care physician to get their annual checkup. This is a quick assessment. They may provide any assessment as part of the initial paperwork, and they notice that this is the percentage that they would screen positive for abuse. And I think this is a very important thing to mention because a lot of the times that's the only time we can provide an intervention for somebody is when they are going for those annuals, because it's more of an obligation to go to those annual checkups versus, if somebody is willing to go to therapy, then they are aware that there is an issue, and of course it'll help to do that. It's more of just being able to catch it earlier on before it gets to the intensity of needing intensive therapy. And then having promising results in reducing risky drug use. All right, so with the application strategy, so we have the service component here with the screening, the brief intervention, the brief treatment, the referral to treatment. You'll have the implementation model that's on the left-hand side of things with, the generalist, the specialist, and the contracted specialist. Then you have the different settings, and then you have the risk factors and severity. So with this, it's the alcohol use, the drug use, tobacco use, and then all of the above. So this just provides a visual model of everything that is involved with this intervention. So with the application, the collaboration is critical, no matter the size of a system. If you have private collaborators or public, there has to be a relationship. So if there's a public agency, they have to be able to have, those resources to be able to connect to others in the, in the immediate system that can help implement some of these tools, or even just referral sources. For an example, on the relationship between a treatment center and a university is, like I mentioned before, in the University of South Florida, on their resources website, our agency, River Oaks Treatment Center, is listed as a resource. So there is that direct connection of like, hey, if you need help with this, this is a place you can go. And then there's the public grant resources, which goes into identifying potential federal, state, and private funding resources. And it's also going to have a need to fully understand the public and private insurance reimbursement procedures and issues. It can get really complicated with these assessments and billing. So this is where you might need to find somebody that understands those things like CPT codes and the billing part, and how do we assess for this, and how do we bill for those assessments that we're doing, and to make sure everything is covered from A to Z. So the medical organizational readiness for change scale, this is where it focuses on understanding if a place is ready for the change, if it's ready to start to implement this intervention. And it includes 18 different domains, which are in the 4 specific key areas, one being the motivation for change, such as the perception of current functioning and needs for improvement. Like if there's an agency that could possibly benefit from this, but they don't see a need for it, it's not going to work. So there has to be that need to want to improve in this. There are the institutional resources, such as like adequate office space, having the staff appropriate, such as with the application strategy and that model matrix. There are different specialists that you may need, or different staff members to address specific things like having licensed therapists, having a medical provider, having somebody that may be able to have more of an understanding with the billing. It's having that staff that's appropriate. The attributes of staff members, such as confidence and counseling abilities and adaptability. This is more of, hey, having a therapist that is comfortable with more solution-focused approaches, where when I'm given a client, especially in my private practice, where I can only see them for 3 sessions because that's all their student resources will provide them with, I need to be comfortable with, all right, I have 3 sessions to do as much as possible and being okay and confident with it. So it's not going to be focusing on so much maybe the basic emotional stressors. If somebody's coming in with, hey, I've been struggling with alcohol use or depression for this long, and identifying healthy coping skills to help decrease those issues. And then number 4 being the organizational climate, such as the clarity of mission and the staff cohesiveness. Obviously, with this intervention, there has to be a lot of cohesion with what's being done and an understanding of, all right, this is what everybody's role is. And the evaluation for the medical organizational readiness for change scale, it focuses on the differences in readiness to change between the clinical staff and administrative staff, and between emergency departments and community healthcare clinics. So this is where any type of agency can use this scale to understand where they are. All right, so when it comes to maintaining the program, here in Florida, it went through Florida Bright, which was the grantee. It is the Florida Brief Intervention and Treatment for Elders. So this was one of the first ones that were provided with this intervention, and they actually developed a sustainability guide for its partner agencies that offers the following suggestions for achieving financial sustainability. So it seems like this agency went through and figured out, all right, so this is what we can do, and everybody else can take a look and hopefully follow this to be successful as well. Number one is checking SAMHSA and the Department of Health and Human Services for funding announcements. Number two, exploring the state substance abuse program funding for both prevention and treatment. Being aware of funding available through local departments of health, education, justice, and corrections. Checking the foundation directory on the Foundation Center website. Asking stakeholders for donations and annuities. Obtaining external fundraising expertise. And starting a related for-profit or not-for-profit business entity or product line that contributes to programming. So all of these things are focused on having the funding available to maintain this program, whether it is from receiving grants on a state level to receiving donations from stakeholders or even like local fundraising that can occur. So, in other words, when they say it takes a village, this is what they're talking about. So some of the bright sites that are included are all of these here. I also provided, there's a map of Florida on the top right-hand corner, where you can see the concentration of a lot of them. As you can see, it seems like there's a lot in Central and South Florida, over there by Jacksonville, but you can also see where there are a lot of empty spaces. So some items to consider for the future and continuing to address substances and addiction and how it is impacting the college-age students is, number one, the prevalence of kratom. It does act as a stimulant at low doses, and it is opioid-like at moderate doses and does cause sedation at high doses. So it seems like it really covers a lot of different symptoms at different dosages. So in November 14, 2017, the FDA did issue a public health advisory relating to the agency's mounting concerns regarding risks associated with the use of kratom. And then they conducted a scientific analysis using a model which provided stronger evidence of kratom compounds' opioid properties. I know that there's been a huge trend with those that are trying to come off of heroin or opiates to use kratom. And what happens is I've had clients that, yes, they're no longer addicted to opiates, but now they can't live without the kratom. And the concern is there isn't enough research to figure out what the long-term effects are because this is a newer substance. And on the top right corner, that is the actual kratom. That's where kratom comes from. That is the leaf itself. So a lot of the excuses too is, or the rationalizations is, well, it's natural, and it's like, yes, well, everything has to come from somewhere. I think that's where a lot of the resistance comes from. Next one being kava, which is being used as a supplement for anxiety and has a relaxing euphoric effect. It's linked to a risk of severe liver disease, long-term use of high doses of kava have been associated with like dry, scaly skin or yellowing of the skin, and then heavy consumption can be associated with heart problems and eye irritation. With kava, there's been a huge trend in kava bars showing up, and I know here in the Tampa Bay area, I've seen an increase in just kava bars becoming open and people being able to go consume the kava or the kratom, and there hasn't been an issue that they have noticed so far. And that a lot of that also has to do with the social acceptance of this newer substance. One thing I did found was this quote. It was from a website. Somebody had a blog, and what they wrote was, "My friend was addicted to kratom, a substance that's marketed to those who have a history of substance use disorder as not really being a drug. Kratom is a plant, much like cocaine. It's a relative of the coffee family, just like the eggplant is a relative of deadly nightshade. It's touted for pain relief, so is fentanyl, and it's thought of as a miracle cure for opioid addiction." This is something that I thought was very powerful because I think a lot of people use the excuse of it's natural or it's a plant or it's not really a drug to help accept their use of this. And then when it comes to cannabis, this is for CBD, which is a chemical compound that's derived from the cannabis plant. And the reasons that most people will use them, it mostly starts with chronic pain and then goes down to anxiety, depression, sleep, and other diagnoses here. And from what you can see here too is a lot of the reasons to use CBD is for self-medicating purposes. I know there are people that are huge advocates of it because it doesn't contain the THC. But again, it goes into the self-medicating and not really knowing the long-term effects of things and how the prolonged use or even just using certain substances for one reason can increase the likelihood of them abusing a substance for can increase their likelihood of abusing a different substance. And these are just the ways that people were using CBD, going from sublingual to vaping. They have the pills, liquids, smoking, edibles, and topical. So in conclusion, the need for continued discussion in an open forum is probably the biggest thing. I think a lot of this needs to be communicated with the young adults, and even starting with students before they make it to college, to be able to allow them to ask questions without judgment of like, hey, if you're curious about using certain drugs, this is what can happen. And having more of that personal approach to things. The increased resource availability for students, even though there may be some colleges that provide free counseling, even just increasing their ability to maybe have more than just 3 sessions or 6 sessions, and then having the support for sober options on college campuses, such as the collegiate program. I think it would be beneficial to have more than just those two. And again, it's focusing on developing a new normal where having substances and alcohol on a day-to-day basis doesn't have to be what, all the cool kids are doing, or it doesn't have to be the expectation for people to be successful. So we're going to be going into discussion and questions. If you guys want to ask the questions down in the chat below, and we can go to answering them. And yeah, so that is a very good point. I apologize, I forgot to mention that. There is trace amounts of THC in CBD. It's just that's what people will say in order to rationalize their behaviors. There have been plenty of clients that I've worked with that go from abusing THC to going to CBD, and it's like, no, it's still in there. So thank you for pointing that out.
Harayli, there was a question from Anne. How are you finding out that a patient has tested positive in a regular exam or urine test? With the patient parent knowledge, or tell them the result after the test? Those are some questions that she asked.
Sorry, is that written down anywhere?
It's in the chat. I can slow down on it. First question was, how are you finding out that a patient has tested positive? Is it in a regular exam or a urine test?
It's usually a UDS, a urine drug screen.
And do they have the parent knowledge?
For those over the age of 18, there doesn't have to be that parent knowledge. I know here we try to encourage family involvement because it's important to have that support. But unfortunately, if somebody wants to keep it a secret, then they end up being able to, and I think that's what happens too, is at the age of 18, they start to learn like, oh, I don't have to share this with my family and I can keep this from them. And I think that's what motivates a lot of people to continue it.
Okay, thank you.
Mm-hmm. Was there another question?
I'm checking. Yes, if a student comes to college on their parents' health plan, are they still limited to the number of sessions, or is that the university's plans that are limited?
It's the university's plans that are usually limited. Usually, if somebody does have insurance, the universities, I think, will encourage them to go somewhere else where they can continue maybe longer-term therapy. So they may not see counselors on that college property.
Yeah, the universities have been pretty overwhelmed with requests for mental health and substance use assessments, and so and historically they've only been able to do an initial assessment or screening and figure out what care the patient, the student needs, and then it sort of becomes an issue for the student and the family to resolve what kinds of care they might need, and then to access benefits for that individually.
Thank you. We have another question. You talked about illicit drug abuse in high school. Have there been any EBP programs introduced that have been proven effective since DARE?
From what I was able to look into, it doesn't sound like there has been. I know a lot of people really focused on the DARE program and the abstinence program, but I think people are recognizing that it wasn't very effective, and I think that they are in the process of trying to figure out what is working, but I wasn't able to find any EBT materials that were proven to show any kind of effectiveness.
Okay, and back to the first question regarding the patient-parent knowledge. The question is, so the student agrees to the drug screen when they're over 18?
Yeah, they would have to agree to complete it. So if somebody goes to a doctor, sometimes for any kind of like primary care physician, you know, especially at 18 years old, you still have your parents making your appointments for you. You'll show up to the doctor. They may ask for a drug screen or a urine test. And that's where they could run the results. But yes, they would have to agree to completing a urine drug screen in order to have one completed.
Okay, the next question is, what Florida university have SUD education as part of their orientation of freshmen, and what does it consist of?
So it looks like every major university has some sort of orientation program. The one that I just happen to have the most insight about in regards to the details tends to be like University of South Florida, because since I do work in the Tampa Bay area, most of my clients go to that university, and they're able to give me the play-by-play about, hey, I wasn't able to register for classes because I had to go through this. But I think a lot more universities are implementing that specific substance use disorder information. But I don't think it's something that's possibly required for all colleges. But I think most major universities are kind of getting into that pattern, especially with what has happened with the Greek life and those news stories.
Yeah, also the resident education, so residential education is the sort of concept that when you've got students in a dormitory setting, you provide leaders for them. Usually it's their resident assistants, and they're there to protect the students from harmful events and lead them. And so a lot of colleges, and I'm not sure the specifics about each Florida college, will train their RAs to identify substance use disorder in the residence in the dorm, and also how to intervene when drugs or alcohol are brought into the resident dorm and a party begins, how to intervene in that situation. So, and then it sort of becomes, what kinds of resources do they have through UHS to get that person or the people involved assessed, rather than just, trying to involve the police. They usually try to get them into some kind of treatment early on. So things have changed quite a bit from earlier days in the last several decades in colleges, where there's less tolerance for on-campus partying and more of a move towards identifying and helping students avoid that kind of behavior.
Thank you. And Harela, you've really covered a lot of great information on these slides, and I know several people wanted to know if a copy of the PowerPoint would be available. And yes, there will be a recording and a copy of the PowerPoint on our site for your review and use. If we'll keep the forum open for a couple more minutes for any more questions. Okay, so we have a question. Are the orientation programs about SUD the only primary prevention attempt to decrease the prevalence of addiction in collegiate programs?
I think for now, yes. I think that's where people are starting to identify, hey, this is something you might run into. I think the rest of the education, such as with, the ESPER program, having those screening assessments done, like an intervention strategy could be that when a student is required a physical or an updated vaccine record from their medical providers, and they have to go through a physical before colleges, having that screening done at that point, having the information provided at that point. And it also comes down to high school, because before college they have to go through high school and having some sort of intervention there. But if there's no information that's provided, then yeah, pretty much I would say orientation is the first dose of, hey, this is something you might run into.
Yeah, I think the colleges are really working hard to try to educate their workforce to make sure that they are providing kind of ongoing education and expressing caution when students are exhibiting signs and symptoms of substance use. I think because of the age, most college students are not of age to even start drinking, but we know that they clearly do often begin drinking in high school, and it continues into college. And then the use of other drugs, as Hareli presented so nicely, has increased dramatically in this current crop of students that are coming through the colleges. And that although drinking remains the most popular drug of choice, that there's a wide variety of synthetic and other kinds of drugs that can be taken through vaping or other creative means to get into the system. And they also, some of them are not easily discovered on a drug test. And so it really requires more interpersonal interaction and assessment of the students going forward.
Are there any other questions?
So I see a few questions here under the Q&A part of it. One being, do you have where I can get the evidence-based material for the brief intensive intervention? So right here under the resources, the first link is the actual expert. It's a lot of information of each process, what it goes through, and the details for each intervention. So that's where some of that information may be provided. I know a lot of them were just more focused on providing that, challenging those cognitive distortions and assessing risk of behaviors. The next question being, what's the current status of drug or alcohol-free student resident dorms? There's one started at TCU and spread to other colleges. So right now, the only ones that I am aware of is obviously any dorm that houses like strictly freshmen would technically need to be alcohol and drug free. Now, like Dr. Murphy mentioned, is even though the legal drinking age is 21, people are definitely drinking under that age. But that's why I also mentioned that collegiate recovery program that is at University of Tampa, University of Central Florida, where it is specific and where there's more of that willingness of wanting to be sober. How do you encourage a college student to ask for help and not to be at risk of being expelled from school? That's a very good question. I think more and more now people are looking into not having that more punishment approach to things, especially if a student is struggling with mental health or addiction, and being more open of like, hey, I need help. Can I get help? And I think that help may be available to them, but I think there's a lot of fear that goes into asking for help that stops a lot of students, because I can talk to a student about like, hey, if you need to take a semester off to go into a residential treatment program, you won't be at risk of being expelled from school or anything or punished for it. They have to get into a point where believing it and understanding this is what you can do, and not being terrified of the system either. But it would also mean them being open about what's going on. They won't be able to do this on their own, and there may be that fear of backlash, even from their family, if their parents, like if they have to go into treatment and their insurance is through their parents, that might be another part of it too.
And then we have one question, brief intensive intervention, is it a curriculum?
Again, from what I was reading on the manual from SAMHSA, it looks like it was more of taking that solution-focused approach. There wasn't a specific curriculum. I will say from this intervention, it looks like it's a figure out what best works for you kind of approach. So in a more hospital setting, like a medical hospital, emergency department, and a brief intensive intervention may look a little bit different versus in a community setting or in a school setting. But I think they were providing different options of, hey, if this is your agency, then this is what might be most appropriate.
Thank you so much, Hareli. And Dr. Murphy, we also want to thank you for your input in the Q&A area. If there's no other questions, we're going to move on to some housekeeping questions regarding the CEUs. Thank you. When I conclude today's webinar, your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number for the first time you register. After you register or sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be Messenger at WebEx. The evaluation will close at midnight on Monday, March the 2nd. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold on for the evaluation.